surgery, some challenging cornea cases. We'd like to have some audience participation if we could. Dr. Terry, pay attention. We'll be calling on you, so stay awake. I'd like to welcome our panel, Dr. Pera, Dr. Karp, Dr. Farid, and Dr. Aiello. We'll all be presenting cases and discussing the surgery. So let's start with the DMAC surgery.
Hello.
Hi, good. How are you?
Hello. I'm good. It's a good afternoon for you guys, but good morning here. Thank you for joining us here in Sorocaba, Brazil. My name is Ana Rita, and I will be coordinating the OR activities today. I'm here with Dr. Rafael Freitas and Dr. Natalia Morin. They will perform the DMAC live surgery today. But first, I'd like to begin presenting you our hospital with a brief institutional video. I think the team has the video with you. Can we play the video now?
In the countryside of São Paulo, one of the largest vision care centers was born. We are BOSS, Sorocaba Eye Bank, an international reference in ophthalmology and the largest cornea donation and transplant center in Latin America. Here, lives are transformed every day because where many see limits, we see possibilities. Founded as a philanthropic organization, BOSS was born with a clear purpose: to promote eye health with quality, compassion, and access for all. We provide both public and private care, with a modern infrastructure and a highly specialized medical team dedicated to caring for each patient with excellence and empathy. Our commitment goes far beyond medical care. We are also a center for teaching, training, and research, contributing to the advancement of ophthalmology in Brazil and around the world. We believe that sharing knowledge is multiplying hope. At BOSS, we welcome all, from children to the elderly, from preventive diagnostics to postoperative care. We offer a wide range of ophthalmic specialties, always focused on innovation, quality, and respect from every individual. Thousands of people regain their sight with us every year. And this is only possible because we believe in the power of solidarity. Because every cornea donation is an act of love that becomes light for someone who lives in darkness. BOSS, Sorocaba Eye Bank. Excellence, vision care, commitment to life. Those who love, donate.
Fantastic. Dr. Prairie, can you comment a little bit about your center there and then introduce the surgical team?
Great. Hello, everyone. So we have Ana Rita that is in the OR today with us. We have the surgeon, Dr. Rafael Freitas. They were both our cornea fellows, and now they're part of the staff from the Sorocaba Eye Bank. And it's a huge eye bank. We have around 1,000 corneas every month from our eye bank, and we perform around 250 keratoplasts a month. So it's a very, very huge, not only eye bank, but corneal transplant hospital. And today we're going to have live DMAC performed by Dr. Rafael, that's staff of our center. Hello, Rafael. How are you doing there?
Hello, everyone. Ready?
Good. Are you guys ready to start?
Yes, we are. So I will give you a briefing case for you just to follow the surgery. Okay, can we start here, Doctor?
Yeah, we're ready.
Okay, so now let's go to our schedule case. We have a 55-year-old male patient who reports blurred vision in his right eye with gradual onset, worse in the mornings, and recalls fluctuating since cataract surgery 3 years ago. His symptoms have worsened over the last 6 months. So he underwent phaco in the right eye 3 years ago and received an hydrophobic acrylic IOL. He currently uses no ocular medication. Systemically, he has hypertension treated with losartan and amlodipine and reports no allergies or relevant family history. On exam, uncorrected vision was 20/50 in the right eye and 20/30 in the left. Best corrected vision improved to 20/40 in the right eye and 20/25 in the left. Intraocular pressure was within normal range in both eyes. For the anterior segment, I will show you some pictures. And fundoscopy was normal in both eyes. So let's review the slit lamp images of the anterior segment. First, in the right eye, you can see a pseudophakic eye with some corneal edema, especially epithelial and subepithelial. We can see here a nice stroma, no scars, consistent with endothelial dysfunction in the right eye. And in the left eye, that appears relatively normal, but we can already see some gutty and initial cataract. So we talked about here about books and patient. And some ancillary exams. The corneal tomography, where you can see the corneal pachymetry. Right eye a little bit thicker than the left eye. Here. And the specular microscopy already showing some data acquisition issues due to severe morphological abnormality on the right eye. But we also see marked endothelial loss and morphological abnormalities too in the left eye. So our plan for today is the TMAC for the right eye. And I will show you the cornea preparation that Dr. Rafael recorded here some minutes ago. And I don't know if Dr. Nicholas, can you comment to this video? I think it will be easier.
Okay, that's fine. So we need to perform and prepare our grafts just before surgery, because in Brazil we don't have pre-cut tissue. So we always prepare our tissue. And you can pass the video, and you can pass a little bit fast so you can have more time for the surgery. So usually we score the periphery of the DSMM membrane to have a point to start peeling the DSMM membrane. After that, we put some trypan blue to see the scored periphery. And after that, we're going to pull the peripheric DSMM membrane under BSS to detach the DSMM membrane. Here he's using some corneal media, but you can use some BSS or corneal media. And after you peel the DSMM membrane, we're going to trifine. Usually we use a trifine number 2.5 millimeters less than the vertical diameter of the recipient cornea. So he probably did that. He probably measured the cornea and discounted 2.5 millimeters. After that, we're going to do a partial trepanation. So here we have a 7.75 millimeters. He probably had a 10.25 millimeters corneal diameter to choose this size. After that, he's going to peel the rest of the DSMM membrane, take the periphery out, and after he had detached all the DSMM membrane, we're going to put some trypan blue for around 2 minutes. Okay, perfect preparation. Let's go for the surgery. Thank you.
I will just share the microscope screen right now.
Okay, thank you so much. I'm Dr. Rafael Freitas, and
We're just starting the broadcast.
Gracie.
Mm-hmm. Just 1 moment. Hello, can you hear me?
Hello?
Hello, can you hear me?
Yeah, we can hear you. The image is outside of the...
Yeah, so I'm just replacing here. I don't know why it's not. Just 1 second. Okay, can you see the microscope right now?
We were seeing the image from outside of the microscope for now.
I'm already sharing our microscope image.
We're seeing the image from outside.
More. Can you see now?
Yes, now we can
There
see
it
it.
is.
Okay, perfect. Yeah, sorry. Let's start.
Let's go. Okay, I start my surgery in 2 side parts, 39. Okay. What?
And Dr. Rafael, are you performing the stripping only with BSS?
Yeah. My first option is the S.I.C.S.S.O. Then my second, I use air and last is the last. Here,
And Rafael, we saw that it chose a 7.75 millimeters diameter graft. Was the size of the cornea 10.25?
yeah.
Okay, so he did what we were telling about that, just discount 2.5 from the vertical diameter to choose the diameter of your graft.
And see them. Again, incision superior frame in my routine.
Então, vai ser cirurgia. Esse quadrado. Eu deixo.
Both December. Normal. 5% removed. Yes, yes.
And Rafael, the size of your stripping, do you have anything that you like to do the size of the stripping? Because we see you don't mark the recipient cornea to perform the stripping. So what size of stripping do you want to do when performing the MAC?
We skip the 1 minute.
Okay.
All the
Yeah, what I understood is they do around 1 millimeter larger than the graft. So you don't have any recipient decimate in the interface that can enlarge the risk of graft detachment. Great.
Check. Go where?
Yeah, so now he's checking the presence of any decimal membrane remnants, because we don't want any decimal remnants in the recipient interface, because that can enlarge the risk of graft detachment postoperatively.
Okay, let me go.
Yeah, and looks everything clean. So there are no decimal remnants in the area of the graft.
place.